Who shared the whiteboard, Priya? Priya?
Deepa have joined.
Okay, ma'am. Welcome, ma'am.
Phone la da.
Oh, that's better, ma'am. Video charge இருந்ததுன்னா video on பண்ணிக்கோங்க, ma'am.
Yeah.
Abhi,
Charge irukku, no problem.
okay. Abhi, are you ready? Abhirami?
Ma'am, I'm there, ma'am. Good evening, ma'am.
Good evening. Are you ready to இதுமா share பண்ணிட்டியா?
Yes, ma'am, share பண்றேன், ma'am.
நீ ஷேர் பண்றியா ஒன் சைடுல இருந்து?
Yes, ma'am, share பண்றேன், ma'am.
Okay, do it. So, Chitrakala, whoever it is, Priya, who is
Ma'am,
there?
this is Banu, ma'am.
Banu, okay. So, thanks, Banu. Shall we start? It's,
Yeah.
exactly it's 6 o'clock.
Ma'am, can I share CVs?
Yes, please.
போடுமா.
Abhi, you can stop share now.
Should I have to stop, ma'am?
You stop share.
Yes, ma'am.
Then only they can put the CVs.
யார் CV போட போறாங்க?
Number CV தான் தேவையில்லைல?
அப்ப வேண்டாம். நம்மளது
Abhi, let Abhi be there. Banu, no need to share any
Okay,
CV.
ma'am. Okay, ma'am. Okay.
Okay.
But just a quick word that Dr. Sampath is the one who's initiated this program itself, and thanks to her for requesting Deepa and me to do the program. With that, I think we can start.
Yeah, we can start now, ma'am.
Can I start?
Planning. Abhi, please start.
Yes, ma'am. Good evening, all. My name is Dr. Abhirami. I'm from Apollo Hospital DNB resident. I'm here to present a case. So the patient name is Mrs. A 29 years old female from Egmore, occupation of housewife, belonging to upper middle class socioeconomic status, came with chief complaints of lower abdominal pain since past 2 hours. The patient's AFI was done, which was found to be 6.5 centimeter and was admitted for observation and induction of labor. Obstetric score is G2A1, LMP is 13/10/2024 and EDD is 29 July 2025. History of presenting illness, history of lower abdominal pain present, pain is dull aching, irregular, intermittent in nature, no history of bleeding or draining PV, able to perceive fetal movements well. Menstrual history, attained menarche at 14 years, regular cycles, 4 days bar 28 day cycle, moderate flow. Marital history, married for 2 years, non-consanguineous marriage, no contraceptives use. Obstetric history, previous pregnancy, there was one abortion at 2024 at 8 weeks, which was missed miscarriage. Medical evacuation was done for the same. Present pregnancy, booked and immunized at Apollo hospitals, 2 TD doses given. Total number of antenatal visits, 12. So first trimester, pregnancy was confirmed by ultrasound at Apollo hospitals after 60 days of amenorrhea. Spontaneous conception, no history of excessive vomiting, no history of fever with rashes, no history of radiation exposure, no history of teratogenic drug intake. Folic acid tablets were taken, glycemic tests were done and found normal. NT scan done between 11 to 13 weeks and found normal. Second trimester, quickening felt at 5th month, no history of bleeding per vagina, no history of pedal edema or headache or blurring of vision, no history of polyuria or polydipsia, no history of burning micturition. Iron, folic acid and calcium tablets were taken. Anomaly scan done at 20 weeks and was found to be normal. Third trimester, fetal movements were well perceived, no history of bleeding or draining per vagina. Iron, folic acid and calcium tablets were taken regularly. Growth scan done at 34 weeks and was found normal. Past history, not a known case of diabetes mellitus or hypertension or tuberculosis, asthma, epilepsy or thyroid disorders. No history of any previous surgeries, no history of any blood transfusions in the past. Personal history, consumes mixed diet, bowel and bladder habits normal, sleep pattern normal. Family history, no history of any congenital anomalies in family, no history of diabetes mellitus or hypertension or thyroid disorders in parents. General examination was found normal. Systemic examination was also normal. So moving on to vitals, pulse rate was 85 per minute, blood pressure is 120/80, respiratory rate is 19 per minute and temperature is normal. Patient's height was 160 centimeters. Pre-pregnancy weight was 58 kgs. Current weight was 67 kgs, and weight gain totally during the period of gestation was 9 kgs. Abdominal examination, inspection, uterus was found longitudinally enlarged, umbilicus in midline, linea nigra, stria gravidarum seen, all quadrants move equally with respiration. On sitting posture, flanks were full. Palpation, fundal height corresponds to term, flanks are full. Symphysia fundal height was found to be 34 centimeters. Abdominal girth was found to be 102 centimeters after correcting dextrorotation. Fundal grip, broad, soft, bulky, non-independently ballotable mass felt, suggestive of breech occupying fundus. Umbilical grip, left side, smooth, curved, uniform resistance felt, suggestive of spine. Right, multiple small nodular structures felt, suggestive of limb buds. First, pelvic grip, hard, round, independently ballotable structure occupying the lower pole of uterus, suggestive of fetal head. Second, pelvic grip, hands were found converging, so non-engaged fetal head. Auscultation, fetal heart sounds heard in left spino-umbilical line below the umbilicus. Heart rate was 140 per minute, normal tone and regular rhythm. So, a 29 years old G2A1 patient at term gestation with oligohydramnios with LMP on 13 October 2024, EDD on 29 July 2025, who on examination had single live fetus and cephalic presentation with good fetal heart sounds, unengaged fetal head, not in labor, had been admitted for induction of labor. So given here is a labor care guideline. So the patient got admitted around 6 o'clock, where induction began at 6 a.m. with Cerviprime gel. At that time, the patient's pervaginal examination finding was patient was 2 centimeters dilated. Cervix was almost 30% effaced, 1.5 centimeter long cervix, vertex at -2 station, membranes were present. So patient was induced with Cerviprime gel. So after 4 hours, which was around 10 o'clock, patient was re-examined, where the patient's pervaginal findings was found to be, she was almost 3 centimeters dilated, vertex same at -2 station, and effacement was same, almost 30%. And Synto, it was ARM was done around 10 o'clock, found to be clear liquor. Synto 5 units and 500 ml of RL was started. And patient was again re-examined around 12:30 p.m., where the patient had variable decelerations. And on examination, the patient was found to be almost 50% effaced, 5 centimeters dilated, vertex at -2 station. Later, the Synto was stopped. So as variable deceleration was present, Synto was stopped and the patient was positioned in left lateral position. Oxygen was given. So the CTG picked up and there was no deceleration. After that, around 3 o'clock, the pervaginal examination finding, it revealed that patient was fully dilated. Patient had bearing down symptoms. So pervaginal examination was done. Patient was found fully dilated. Vertex at 0 station. And the patient ultimately delivered a normal vaginal delivery with right medial lateral episiotomy was given and delivered around 3:30 p.m. So given here the CTG showing variable decelerations, which was around 12:30 p.m. Thank you, ma'am.
Thank you. In that CTG, is there a toco probe, ma?
And tocoprobe was there, ma'am, which was it's given.
Okay. No. Now the whole picture has come. Okay, fine.
Yes, ma'am.
Yeah. No. Earlier I had only the fetal heart tracing alone was there. Okay.
Okay, ma'am.
Yes.
See, can I ask, madam?
Yeah, go ahead. Just start.
So, how will you define oligohydramnios? Is it oligohydramnios? How will you define?
Oligohydramnios where the single deep vertical pocket is less than 2 centimeter, or to all 4 quadrants as a sum of all 4 quadrants less than 8 centimeter, ma'am.
Is that oligo? What is the definition, ma?
Ma'am, where there is insufficient volume of amniotic fluid around the fetus during pregnancy, ma'am.
That's
Okay.
called
Abhi,
lab.
tell it objectively.
Objective. 8. Is it 8?
It is not 8, Abhi.
Yes, ma'am.
It's 5, ma'am.
Yes.
It's 5.
Yeah.
Correct.
Who said that? Yeah. So
I
where
think
is this definition of 5 given, ma? Pooja? Was it Pooja who answered or Abhi?
It was Pooja only.
Yeah. Okay. So where is this definition given? You're right. It's 5. Where is the definition given?
Abhi, can you stop sharing your screen?
Yes, ma'am.
Anyway, thank you for the presentation, Abhi. We'll just discuss the details now. Thank you.
Yes,
Because
ma'am.
I'll just put
Thank you,
the
ma'am.
PPT in a proper way so that everyone can see it. It is in the crossword. That's the reason. Okay.
Yes, ma'am.
You know, at first thing I couldn't see the Toko recording at all in that.
Okay.
Yeah.
So, Abhi, see, this is 6.5 centimeters. When you say oligohydramnios, it is 5 is a
Yes, ma'am.
definition. But you are really
Okay.
concerned at 6.5 because she came with an abdominal pain. Okay.
Yes, ma'am.
So,
Okay.
6.5, it is either it is pathological oligohydramnios, like is it associated with any ultrasonogram findings of fetal growth restriction or small for gestational age, or with any Doppler abnormality. Have you mentioned what will be the antenatal ultrasonogram, growth scans, and other things? So we need to really
Ma'am,
check.
all
Yeah.
Ma'am, all the growth parameters was found normal, ma'am. Just it was like idiopathic oligohydramnios.
Good. So idiopathic oligohydramnios, but we still not uh, exactly looking into isolated oligohydramnios because 5 centimeter is a diagnosis. So, but you are still concerned 6.5 centimeters because she comes with an abdominal pain. So while in the abdominal pain, you decided for observation. So how long you observed her? You directly.
Ma'am, the patient came around at 11:30 p.m. At night, ma'am. We observed her overnight, and morning around 6 o'clock, we re-examined the patient, and then AFI was done, which was confirmed, and then we started with induction, ma'am.
Okay. So why you selected the prostaglandins inductions? Any
Cervix, it was not very much favorable, ma'am, for inducing. So initially, for ripening the cervix, gel can be used.
Okay.
Prostaglandin.
So did you thought about any Foley's inductions? Because it is an oligohydramnios, borderline oligohydramnios, whatever it is. Would you worried about when the contractions comes? You know, prostaglandin will cause hyperstimulations. Okay. So already there will be restricted fluid here. Would you thought about hyperstimulation and cord compressions as the labor progresses? And would you thought about giving for mechanical methods?
Mechanical also can be tried, but for this patient, a gel was chosen for
Ilma,
proceeding with
what she's
induction.
asking is, you have decided to induce.
Yes,
Okay.
ma'am.
So in this situation, given the oligo, is prostaglandin, given the fact that you can go for hyperstimulation, not necessarily when labor progresses, you can get it even as soon as you put in the gel. Is it the right choice, or would you consider something else, is what she's asking. If you will, what will you consider?
A mechanical method of induction, like Foley
What
induction,
is
can
the
also be
advantage
considered.
of, what would have been the advantage of mechanical over PG in this situation? Why? Or do you think there would have been or not?
Uterine hyperstimulation would be lesser when comparing with prostaglandin analog, ma'am, in case of Foley induction.
Is it? Is it?
You said Foley
Okay.
is mechanical, Abhi.
Yes,
So,
ma'am.
so uterine hyperstimulations is more in Foley inductions or in prostaglandins, which is safer.
Mechanical method is little safer than
Very good.
a prostaglandin.
Okay. Right. And we'll move on to the next point, Deepa.
Okay.
Yeah.
So when you say it is an induction of labor, how will you monitor during the induction process? That is what you call as a you for 6 o'clock you started induction. So 6 to 12 o'clock, 12:30 only she is becoming 5 centimeters where she is eligible for her labor care guide. So during this
Yes, ma'am.
process, we call it as a latent phase. Okay. So she is already a borderline oligohydramnios and now induced. So how will you monitor her latent phase? How often? Like monitoring,
Ma'am,
it is a maternal monitoring support system. Whatever the LCG, we will be subconsciously we monitor in the notes. No, what are all the things? How often you will do monitoring of the mother? What do you do about the
fetal heart rate monitoring can be done once in half an hour, ma'am. In latent phase. And maternal maternal parameters like vitals, pulse rate, BP, and then temperature can be monitored once in 4 hours, ma'am. Pervaginal examination can also be conducted once in 4 hours.
Why you do a pervaginal examinations in a latent phase for 4 hours? So latent phase, what do you consider is like it's a high risk labor, like you are going for an induction. So and all you chosen your drug of choice is prostaglandin. So this lady should not left unattended, correct?
Yes, ma'am.
So every 1 hour nurse has to be attend her to check for her contractions as well as fetal heart. So every 1 hour, how many minutes you have to do it, like intermittent auscultation, or you do a CTG assessment. CTG assessment, if at all, if you are doing, probably if the contraction is not there, every 4 hours, we will be doing a CTG for 30 to 40 minutes. But 4
Okay, ma'am.
hours, you should not left unattended. You have to do an intermittent monitoring of maternal vitals as well as the fetal heart rate.
Okay,
So
ma'am.
why it is so important? Why it is so important?
To
Sometimes
assess maternal fetal distress. Yes.
maternal hyperstimulations, by looking into the palpations, we will see how many contractions he is getting. If it is getting, she is getting 3 contractions, strong contraction, then we automatically do intensive monitoring. And also, if she vaginal examination, probably if she requests pain, you do earlier. If she doesn't have any pain and if she is going smoothly, only 4 hoursly monitoring is enough. CTG monitoring is enough, right?
Yes,
You
ma'am.
understand the importance in the latent phase?
Yes, ma'am.
Okay. So after the gel 10 a.m. you examined her. Why you did an ARM at that time? It's 3 centimeters -2 station 30%. How was her contraction that time?
Contraction was almost 3 contractions lasting for 35 to 40 seconds, ma'am, in 10 minutes. Intensity was not very strong, ma'am. So to help in augmentation of labor, we proceeded with
Each contraction 10 minutes, each contraction lasting for how many seconds?
30 to 35 seconds, ma'am.
So is that adequate or not adequate?
It is not very much adequate, ma'am.
What is the definition?
2 to 5 contractions lasting for 20 to 60 seconds, ma'am,
Mm.
in 10 minutes duration.
5 contractions in 10 minutes.
Yes, ma'am.
So Deepa,
2
would
to
you
5
give that a different definition?
Okay, we are
Ildama?
still in the latent
Okay.
phase, ma'am. So even in an active phase, what was it here? We are seeing it like the contraction. When you come into the contraction, if it is less than 2 or less, then only will be giving us augment the labor, or if the duration is less, the contraction duration is less than 20 seconds. This is even when she is 5 centimeter dilator. We are still in the latent phase and we have given gel only 4 hours ago.
Mm.
Okay, 6 o'clock you put a gel, and 10 o'clock, that is 4 hours, you did a reassessment, maybe because the contractions are frequent, or she may request the pain. So that was the intention. You did a PV and you said is 30% FA, 3 centimeter dilated, -2 station membrane pleasant. So my only
Yes,
question,
ma'am.
what is the necessary for augmentation ARM at this point? When she is already getting 3 contractions, each contractions lasting for 30 seconds. See, usually after the gel Abhi, the rule
Yes,
is
ma'am.
after 6 hours only, you have to at least wait for 6 hours. Why we have to wait for the 6 hours? After prostaglandin, you have to wait for 6 hours either to start ARM or to start oxytocin. What will happen if you do a ARM now? What is the intention of ARM is to stimulate augment the labor. How it is going to augment the labor?
It will cause the fetal head descent will cause mechanical stimulation and will augment the labor.
Did anyone can join the conversations from to Abhi? Anyone from the audience? Can you all able to see the screen, right? Abhi,
Yes,
can you
ma'am.
able to see the screen,
Yes,
right?
ma'am. I'm able to see, ma'am. Yes, ma'am.
Convinced that contractions, if it is 3 contraction and 35 seconds is adequate not to give us into. That is what we are practicing LCG. Now we are still in latent phase. So Abhi, so ARM will
Yes.
stimulate prostaglandins. So increases the natural endogenous prostaglandins. So again, already we have given prostaglandins, and this endogenous on top of it will cause more hyperstimulation. And
Yes,
there
ma'am.
is a liquor is needed for a 6.5 centimeters AFI. So we need a cushion effect till it goes till labor. Then only we can prevent the cord compression. As long as it is progressing very well, 3 contractions in 35 seconds, we need an ARM bag, one for cushion effect to prevent the cord compression. Second is
Okay, ma'am.
like by doing an ARM, we are getting more trouble, more hyperstimulations, more need for more resuscitations. Okay.
Okay, ma'am.
Okay.
Okay.
Okay. Sorry. So this is how we have to do. So next, suppose if she is in latent phase, let her more, give her some kind of pain management for her pain, and in the form of opioids or some kind of gases or some kind of paracetamol, IV paracetamols. You can ask her to move around. So next assessment will be exactly 6 hours will be the better assessment. Or otherwise, if she is having urge to push or some kind of increasing pains, requesting painkiller in between, or if you feel any fetal heart rate changes during the auscultation or during the CTG. So when do you start a continuous CTG? Will you start continuous CTG or will you go ahead with only intermittent CTGs?
Ma'am, once she gets into active phase of labor, ma'am,
Okay, what is active phase of labor?
Where dilatation is more than 5 centimeter and contraction lasting for 3 to 4 contractions lasting for more than 40 seconds, ma'am.
3 contractions lasting for 40 seconds, and then
More than 40 seconds.
more than cervix dilated more than
5 centimeters, ma'am.
Okay, very good. So 5 centimeters is a WHO category. So that is why we are still then 2020. From 2020 onwards, previous is only 4 centimeters, but there is no hard and fast rule. Someone having a good contraction, 3 to 4 contraction, and staying there in the 4 centimeters for a longer time, say around 6 hours, 8 hours at the same stage, then we need to intervene. You understand?
Okay, ma'am.
So you cannot leave her alone because just because she is not in an active phase, I won't do continuous monitoring. No, she getting a continuous contraction, 3 to 4 contraction, efficient contraction, lasting longer. Then at 4 centimeter also she is eligible for continuous monitoring. Okay,
Okay, ma'am.
Jaishi ma'am.
One sec. Lassie, no, wait. Sorry, Salma.
No,
Somebody's
no.
come and she's barking. I'll go to another room.
Okay.
Ah.
So you did a reassessment at 12:30. When did you start oxytocin?
Oxytocin was started around 10 o'clock, ma'am.
So after as soon as you are done, you have started an oxytocin?
Ma'am, after ARM, we waited for around half an hour. Around 10:30, we had started, ma'am.
What is the rationale, ma? Is there any time guideline, or is a half an hour an arbitrary? You said purpose of doing ARM, one of it was to augment the contraction, right?
Yes, ma'am. Yes,
So
ma'am.
how long would you give? You have to give time, no? Would you start in half an hour, or would you give some more time?
We would have waited a little longer, ma'am.
Little longer is how long?
Almost for 2 hours, ma'am.
2 hours or 2.5 hours? 3 hours? How will you decide?
Ma'am, depending upon the contractions, how often?
Okay, right. So is half an hour, if you have started, was there an indication to start it in half an hour?
No, ma'am, we would have waited longer.
Longer. Okay. Yeah, so what we're trying to tell you is that any action on our part must have an indication. Okay.
Okay, ma'am.
And you must
Okay.
follow the guidelines, like, how often you do PV, how often, why you would start an AR or do an ARM. So, Elame, we have to follow the instructions. Follow the guidelines. So,
Okay,
just
ma'am.
like that, half an hour later, we should not do it. Okay.
Okay, ma'am.
Right.
Okay, ma'am.
So, it's a good idea to just read up more in detail about this.
Okay, ma'am.
Okay. Then.
So, so the clear-cut idea is like when she is in latent phase, when you did a PV at 10 p.m., you could have waited when there is an adequate contractions. Okay, of course, you reassess within 2 hours at 12:30. That also need a rationale why you did a reassessment at 12:30. You have to reason out why you did a reassessment. So reassessment at 5 centimeters, that 12:30 only you started having labor care guide. Shall we go to the labor care guide? 12:30, 12 o'clock or 12:30 you did a reassessment?
Ma'am, it was around 12:30, ma'am.
12:30. Okay. So when you do notice a variable decelerations in the CTG, you did a reassessment, right? This is
Yes,
a
ma'am.
This is a CTG.
Yes, ma'am. Yes,
So,
ma'am.
so can you read this CTG, Abhi, in a DRC, Dr. C. Bravado, in a protocol wise? Can you read this CTG?
Yes, ma'am.
Human's benefit.
The CTG, it shows baseline fetal heart rate around 140 to 150 beats per minute with good variability and acceleration. There was there was variable deceleration which was observed around 12:30 p.m. after starting with Sympto. After which we had stopped the Sympto and oxygen was started with the patient, and patient was positioned in left lateral. There was the CTG picked up after the variable deceleration. Ma'am.
Okay. Sorry.
Oh.
Sorry, ma'am. I'll just
Yes.
ask. Okay, so when you read the CTGs, you said it is 12:30 and someone is signed at 12 p.m. The date, what it was mentioned here is 2:30. So you have to 2:30, 2:50. So this is more important. So medical legally it is very important because whether it is a 2:30, but someone is signed at 12 p.m. only. That means it is a 12:30 CTG only. Why it's so important medical legally? Because it was dated somewhere around 02:30. So the machine is not calibrated according to a real-time date.
Okay, ma'am.
Okay, so you have to, once you enter into next time enter into a labor room, please change calibrated the correct date and time set. It was not set here. This
Okay,
CT
ma'am.
only speaks medico-legally. Okay, sorry. Madam, you can ask, ma'am.
Yeah. No. So that's what one thing is always good to follow the same thing. Ma, I know we are discussing this case, and halfway through she said, read this CTG according to the Dr. C. Bravado. Now start
Yes,
off
ma'am.
again with defining risk. Nothing wrong. Okay.
Okay, ma'am.
Quick
Okay.
2-3 lines about what this case is, and
Okay.
then go on to contractions,
Okay, ma'am.
and then go on to the baseline.
Okay.
So I'll follow that order always. That's what I want to tell you. Then we
Okay,
can
ma'am.
we can
Sure.
never go wrong then. One.
Okay, ma'am.
Two, I think Deepa's point about time is extremely important. Even as you are, even in an exam, if somebody gives you a CTG and you can see that somebody has signed over there, then quickly look at the time. Okay.
Okay. Okay, ma'am.
Somebody could have signed at 4 p.m. That's different.
Okay.
They could have signed it retrospectively. That's different. But this has been signed as 12:30.
Yes, ma'am.
And the timing. So it's the point we're trying to make is you have to be extremely alert. You have to look at every single point.
Okay, ma'am. Okay, ma'am.
Okay, sure. Like, okay, now we take it for granted that it's actually 12:30.
Okay.
And
Yes.
so you'll have to follow that Dr. C. Bravado follow panna. You'll never miss any points.
Okay, ma'am.
Right. Okay, then next was this was what, 240. Okay. So how is the CTG evolving? Are you worried about it? Is there something happening little later on?
Uh, Patient started, fetal heart rate started developing variable decelerations, ma'am.
Okay, and you seem to have started oxygen.
Yes, ma'am.
What is the reason for starting oxygen?
Ma'am, the
What's
fetal
the
heart rate deceleration, it could be due to cord
is there
compression, ma'am.
is there evidence that fetal oxygen saturation is improved by giving the mother oxygen?
Uh,
What do the guidelines say?
Oxygen could improve decelerations, ma'am.
Now we're getting into trouble. Oxygens cannot improve decelerations. Right?
Okay, ma'am.
If at all it's going to help, you are thinking it's going to help the fetal oxygen saturation. But
Yes,
we
ma'am.
feel that it's only going to help the maternal oxygen saturation. Are we right or
It
wrong?
could increase the placental, like increasing the availability of oxygen in the placenta. So uteroplacental circulation might.
It's being compressed, right?
Yes, ma'am.
Okay, so I think little bit of homework here you need to do.
See,
Yes? Okay.
oxygen will not help for in utero fetal resuscitation. Okay.
At all. That's a very, very
Okay, ma'am.
fundamental point, ma.
Only
Okay,
time
ma'am.
Only time it will improve is only when the mother is having a distress, mother is having eclampsia, throwing fits. Okay, because of the
Oh.
eclampsia, having an acute bradycardia for the baby, oxygenizing the mother will help the baby because here the mother is oxygen deprived. Here the deceleration is because of the cord compression. By compressing the cord is already compressed. So how to relieve it? Okay, so you relieve the cord
Okay.
compression. Okay, by putting a patient in the left lateral position. Here you see there are so many contractions. Okay, these contraction is not even going into the baseline where the baby is going to get a decelerations or going to get a uteroplacental perfusion. So there is no rest period. So you have to improve the rest period. So we have to reduce the contractions. Then only the decelerations will. So how to reduce the deceleration? You have to think about contraction. You have to think about going for terbutaline. So left lateral positions, IV fluids and terbutaline. Terbutaline is
Okay, ma'am.
tocolytic. So tocolytic,
Tocolytic.
okay, is the only way to improve the oxygen supply for the baby. It is by giving an oxygen will not go and deliver to the baby at all. It's
Okay,
really
ma'am.
cord compression. Baby is getting, most of the babies in labor will be having a cord compression. So all the babies, if your reserve is good, they will go through the deceleration. So if you see a variable deceleration like this, are you really concerned? Variable deceleration is with very good
Actually,
visibility, good
yes, ma'am.
baseline heart rate, the baby is very stable.
Yes, ma'am.
Okay.
Oh.
Okay.
If there are typical variable decelerations, it's not a very great concern, ma'am.
Okay. What is typical variable deceleration? Tell me.
A typical variable deceleration is that deceleration less than 60 beats per minute, lasting for less than 60 seconds. And there is maintaining or variability, baseline variability is maintained. And there is a shouldering effect where there is before and after the onset of deceleration, a slight increase in fetal heart rate will be seen, ma'am. If these parameters are there, it is defined as typical variable decelerations, ma'am.
Okay. A typical, that terminology is taken out. Anyway, you have,
Uh,
that
yeah.
is, it is a shouldering after the variable deceleration is called overshoot. That is a dangerous. Okay,
Yes, ma'am.
shouldering is only that before the deceleration. This is called a shouldering. This is okay, but
Okay,
this
ma'am.
shouldering happening after the deceleration is not at all good sign. It is called overshooting. Fine.
Okay, ma'am.
Okay, are you
Okay, ma'am.
is this a typical or atypical then? Anyway, with the terminology has not been used. Okay, it's
Okay,
only
ma'am.
complicated and uncomplicated variable deceleration.
Okay, ma'am.
Okay. So
Okay,
it's a
ma'am.
complicated or uncomplicated variable decelerations.
Uncomplicated variable decelerations, ma'am.
So uncomplicated variable deceleration going for 90 minutes. Okay. What does the guideline say? It is a white line, it is an amber, or it is a red category. That means it is normal or suspicious or it is pathological. I'm seeing this variable deceleration for almost 90 minutes. Is it normal or is it suspicious or is it pathological?
If seen for 90 minutes, pathological, ma'am.
It's normal. Okay. So complicated variable deceleration only comes into the suspicious or pathological variety will come, depending upon how long it lasts. So all variable deceleration still comes under the normal category, which is not a complicated thing. Complicated,
Okay,
as
ma'am.
I say, it has to be broad, okay, and there is
Okay.
no variability in the decelerating arms. If it is a good variability,
Okay.
still it's okay. Or if it is like a more of W shaped and it is not stable in the baseline, it is going up and coming down and stay the whatever the amount the baseline it is staying, it's less than 30 seconds. That means less than one small square. And again, it is going for a deceleration. These are all the called complicated variable decelerations. Okay. This
Okay,
complicated
ma'am.
deceleration lasting for less than 30 minutes is suspicious. More than 30 minutes is called pathological.
Okay, ma'am.
Okay.
Yeah, so the pathophysiology is extremely important here, ma.
Okay, ma'am.
Okay, we should not just look at it and make a inference. Extremely important. So I think you should really read up the pathophysiology once. Only then we can
Okay, ma'am.
interpret the CTG and only then we can put it to the clinical thing. So I think today you
Okay.
just read up completely on the pathophysiology of D cells.
Okay, ma'am.
Okay,
So,
then what happened after that? Now let's move on. We've given oxygen, D cells are settling, is it? Towards the end of that
Yes, ma'am.
CTG?
no, this is after
Decelerations are
2 hours. This is after 2 hours, just before deliver.
Okay, 3 p.m.
Yeah, 3 p.m. She started pushing and 3:30 p.m. she delivered. Correct?
Ma'am,
Delivery
this was
happened.
actually the variable deceleration which was present earlier, ma'am. After that, it
Okay.
had improved.
Okay, ma. So number according to our time, this is probably around 2 o'clock or so. Are we right?
Yes, ma'am. Yes, ma'am. It's around 1:30.
Okay. 1:30. Okay, fine. So then
Okay.
at 1:30,
So
if this is the trace, what is the further trace?
further trace was not there, madam. Only these
Not
two
there.
traces. That was improved after oxygen started. This was a deceleration, that is 12:30 to 2:30 scenario, this one.
Mm, mm. So Abhi, so does it mean that after that it stabilized and then she went on to deliver? Is it the diesel stopped?
Yes, ma'am. Diesels had stopped and patient delivered normally, ma'am. After that, there was no deceleration. Towards the end, there was a little bit of early decelerations, ma'am, when she was about to deliver. In between, the CTG tracing was normal, ma'am.
Okay. So second stage when pushing, do you keep the CTG or do you remove it?
We actually remove the tocoprobe, ma'am.
Why?
Fetal heart rate will be kept on.
Why do you remove the tocoprobe?
When the patient is about to push, ma'am.
Without toco, how will you interpret CTG? Will you be able to call it, categorize the D cells then?
No, ma'am.
Okay. Right. So I know it's common practice to remove the toco, but it is not a good practice to remove the toco.
Okay, ma'am.
Okay.
Okay.
So always keep it on. I know in every single labor room, this is what is being done, but it's not the correct thing to do. You must keep the toco on. And then, but you continue the fetal heart, is it? Tracing? Or you listen intermittently?
We listen intermittently, ma'am, not continuously.
How often?
Like once in 5 minutes, ma'am.
4 in 10. So when will you listen to the fetal heart? She's contracting 4 in 10, she's pushing.
Like once in 5 minutes, we listen to fetal heart rate, ma'am, intermittent.
Okay.
In between the contractions.
Okay. So what is your objection to keeping the fetal heart probe there?
To look for any decelerations, ma'am, fetal heart rate.
Anamalla, what is your objection to keeping it there? Why are you doing intermittent listening to it?
Like head descent, ma'am, it would be there, so we'll not be able to correctly position the probe, ma'am.
After it goes into the pelvis. But where was our station of our head now? When she reached full dilatation, what was the station? What was
Yes, ma'am.
palpable per abdomen?
Less than 2/5 palpable, ma'am.
Okay, so where was the
Almost
palpable
it
part?
has crossed zero station, ma'am.
Cross zero station. Okay. Was she pushing at that stage?
Patient started pushing around 3 o'clock, ma'am.
Mm.
Zero station, it was seen around 2:30 to 3 o'clock. And we did the pervaginal examination. Vertex was at zero station, ma'am. After that, patient started pushing. From 3 to 3:30, patient delivered, ma'am.
Okay. Right. Yeah. Anything, Deepa?
Okay, so as madam said, the second stage CTG is more important here. You have to put a toco probe as well as a CTG probe. Whether the patient sitting on the ball or squatting on the table, whichever the positions like a patient is adapting, the CTG has to be there. Okay,
Okay,
patient
ma'am.
can
Okay.
with the background, patient can do all those things. Okay, so that's one important thing. Since your patient has quickly gone through the second stage, there is not much about the second stage here. So the learning point in the 12:30 to 3 o'clock, the CTG has to be continuous and it has to continue in the second stage. When you see a variable deceleration, you look for the induction of labor with oligohydramnios. You have to look for, once you see the variable deceleration, you have to look into the contraction, because contraction is more, the decelerations is going to be more. So if you need a proper rest between the contraction, even in this, no, there is no rest
Yes.
period. It is totally going contraction. So you need to make this uterus calm for the baby to get more oxygenations. Okay, so more blood
Okay.
oxygenation. So your ideal thing is you should not use oxytocin at all during the labor if she is getting these contractions. So stop Synto and see her how contraction. Even after another half an hour, if she progresses, is fine, because her active phase progress is so good. Okay, so we don't want the baby to make it hypoxia. So this contraction has to be normalized. Even in the second stage, you have to see a four or five contraction. You have to see the relaxation between the two contractions. That is the most important thing. Then automatically all your decelerations will settle. Okay, so that's it. So
Okay, ma'am.
there is no variable deceleration. Even there is variability is fine. Even a normal CTG, if you baby is having more, if you see the TOCA or if clinically the intensity is more, that is what the guideline says, right? That is what the guideline says. Okay, so what happened if
Okay.
what the guideline says, LCG says here, if your contraction is more than 5 or if the intensity is more, then it is comes under the red category. So you have to alert. Then here you have to stop symptom. You cannot continue the
Okay.
symptom when you haven't enough, because we are making the baby more distressed. So LCG is
Okay, ma'am.
more important. Each and every point you are doing it, you have to put the alert signals. So in the first supportive care, if the patient is supine, no, she cannot lie down supine. Either you have to move around, either in the left lateral position if she is lying down, or she has to sit in the birth ball, or she has to squat, or she has to kneel, whichever, never in the supine position. The best thing is lateral positions in the even in the second stage for longer time. And here
Okay.
everything is fine. Okay, so there
Okay,
is
ma'am.
transverse P or transverse position. Again, you have to put a red signal over here. So if it is a
Okay, ma'am.
transverse position, then we have to see whether how what is the it is going to be taking a little longer time. So that is also there. Then molding on caput is not that, but molding is 1 plus. It is still, it's okay in the early labors. Molding is only 3 plus. It is coming into the red category. The importance of maternal vitals. Okay. So what happens if the mother's pulse rate is 120?
It would affect the fetal heart rate also, ma'am.
Affect the heart rate. We have to look for any maternal sepsis. Is she going in for any you have to look for the temperatures, all those things. That is the reason, even in a latent phase, when a high risk mother is going for labor, your monitoring has to be maternal monitoring has to be frequent, as well as the fetal monitoring, not necessarily. And it is a good practice to do urine dipsticks every 4th hourly in the active phase. We used to do it in labor room in government setups. All patients will come with the urinary things. But in our labor, especially our Indian populations will have more of acidotic in labor. They get dehydrated more. So we'll come to know if the dehydration, if acidosis is positive, this comes under red line. Then that tells the baby is going to get affected with the high dehydration, as well as the mother will be exhausted soon. So that is better if you do it. If it is negative, that's fine. That means you have done it. It is negative, right?
Yes, ma'am.
Okay. So you have done your urine every 4th hourly and put it across. That's fine. So if all other parameters fine, then your lady can sit in the 5 centimeters for 6 hours. That's good.
Okay, ma'am.
Okay, 6 hours, then we can wait. We cannot wait for the 5 centimeter for more than 4 hours or 5 hours. When there is a fetal distress, when mother is dehydrated, when there is a temperature, when there is a meconium, when there is a bleeding, all those things. Okay, so we have to
Okay,
see
ma'am.
what happened before it comes for a longer time. Your lady is progress very well. That's fine. Okay. So what did you learn, Abhi, today?
Ma'am, initially, starting with the method of induction, ma'am,
Mm.
like a mechanical method instead of gel prostaglandin analog can be used, and oxygen should not be used for resuscitation, ma'am. Like it has no role in resuscitation,
Very
Okay. Next.
and like we can wait. Once starting with one method of induction, we can wait at least. We have to give it time for the method to act, ma'am. We shouldn't rush into other methods of induction. Like after VRM, we shouldn't start Synto immediately.
Induction or augmentation?
Augmentation.
Mm. Okay.
Mm.
And second
I
stage.
have to still learn about the the deceleration part. No?
Right. And then the second stage, as Deepa was saying.
It's a high risk pregnancies. Okay, so though you
Okay,
chosen
ma'am.
for intermittent auscultation, okay, it is better to have a
Continuous.
CTG monitoring.
Okay, ma'am.
Why continuous CTG monitoring? Because late in the active phase itself, you only mentioned she had a variable deceleration, which makes you little concerned.
Okay, ma'am.
That's the reason.
See, the once in 5 minutes is actually not a good idea at all, ma'am, because as I told you, if she's contracting 4 in 10, where are you going to get a gap to listen once in 5 minutes? And then for how
Okay,
long will
ma'am.
you listen? Before you start listening, the next contraction is going to start, isn't it?
Oh, yes, yes. Yes, ma'am.
So it is always good. And in a way, actually, it also gives you an idea of the descent of the head. Okay, in this case, our head was well down. But if the head was like little higher up when she started second stage, and it would actually tell
Okay.
you, how it is descending also as your fetal heart position moves down. So these
Yes,
are all
ma'am.
indirect ways also of finding out.
Okay, ma'am.
Okay, both rotation and descent can be made out by the position where you're finding out the fetal heart, where you're picking up the fetal
Okay.
heart. I mean, these are just clinical tips which you may not get in any book.
Okay, ma'am.
As it's advancing, it's going from transverse to OA probably,
Okay, ma'am.
and same way it's also descending. So I think overall, try to keep the TOCO as well as the fetal heart on a continuous monitor.
Okay, ma'am.
Okay. Now, this
Okay.
lady delivered in half an hour, but if she didn't deliver, say she was fully dilated for 1 hour, at, as you said, +2 station, is it?
Yes,
Below
ma'am.
the
Zero.
spine. Okay, below the spine.
Yes, ma'am.
Instead of half an hour, she's 1 hour, 1.5 hours now. 1 hour. She hasn't delivered.
Okay,
What
ma'am.
would you have done?
We could have waited a little longer, ma'am.
How long?
Like for primary, we can wait up to 3 hours, ma'am.
Okay, but this lady, is she high risk or low risk? And 3 hours is for high risk or low risk?
It's for low risk, ma'am.
Okay, but our lady is, I think Dr. Deepa just called her high risk. Was she correct?
She's yes,
Was
ma'am.
she high risk?
Oligohydramnios
Mm.
and presenting with variable deceleration in between.
Okay. So will you wait 3 hours?
We can wait a maximum of 2 hours, ma'am.
Okay. Aprom?
Uh, we have to assess and see what is the cause of prolonged labor.
What are the causes you are looking for?
Like it could be cephalopelvic disproportion.
Okay. How will you make a diagnosis of cephalopelvic disproportion at this stage? +2, 2 hours in labor, good contractions, fetal heart good. How will
We
you
can
make
use
a diagnosis?
any other.
So is the diagnosis, you are diagnosing that there is a problem. Okay, that's accepted.
Okay, ma'am.
But is
Okay,
the
ma'am.
diagnosis of CPD correct, or is there some other name you would like to give it? And is there a problem really?
As it has already come to +2 station, we can try any other methods like instrumental delivery can be tried, ma'am.
Okay. What instrumental delivery?
Forceps or vacuum can be tried for
Is she satisfying the
delivery.
criteria for forceps? How will you find out? How will you find out? Now, regular what we do then, nothing new, no? What, Abhi? I'm just asking straightforward questions. Yeah, what all of us are doing in the labor ward, no? So you have decided to put forceps. Okay, now if it was me, I would have put vacuum. So I'll say it doesn't matter what the position of the head is, where the fontanelles are. It doesn't matter whether it's deflex, whatever. I will put vacuum. But if you are going to choose a forceps, what are the criteria that you want to satisfy? You will do a PV, right?
Adequate
putting.
pelvis. Yes, ma'am. Adequate pelvis. Head should have engaged, and
Mm.
membranes absent, ma'am.
Okay. That's enough for forceps application.
Um,
What else? Deepa, am I asking anything that
Yeah. You are asking very good
anything
question.
that I shouldn't be asking?
No. Okay. Oh. So, Abhi,
Bladder should be empty.
Sure, good. Okay, bladder should be empty. வேற என்னம்மா ஒரு முக்கியமானது before you put forceps? Okay, what type of forceps are you going to use?
low mid cavity or outlet, which one you choose? Because you only said Abhi forceps.
Yes.
Okay, so what do you have the practice like +2 station with caput 2+ or molding 1+? That is what we can carry out the same thing. With
Yes,
that +2 station, will you wait for some more time and it is fully rotated anterior. So
Yes,
what do you
ma'am.
do with
She's
that
giving you the answer now.
anterior?
What, Abhi?
Subconscious.
Rotation should have completed, ma'am.
So what are you looking for in the straight line? When you do
Occipito
a P,
anterior. Yes, ma'am.
occipito anterior, how will you diagnose occipito anterior? You know it, ma. Come on, you must tell. அவ்வளவுதான் வேற ஒண்ணும் இல்ல. I'm not asking anything difficult. You know the answer. What suture should be where?
So sagittal suture, ma'am.
Should be
Uh,
it should be where? In the AP diameter or in the oblique diameter or in the transverse diameter?
AP diameter, ma'am.
Okay. And then which fontanelle should you feel or not feel? Suppose I tell you I can feel the anterior fontanelle. Will you put forceps or not? Anybody else also can answer, ma. Need not be only Abhi.
Kirtana, you can answer, Kirtana. You're asking some questions, so you can open your mic, unmute yourself. Satyam.
Abhi,
Okay.
Cholma, you know the answer. Come on. Tell us what it is. Sorry, suppose I tell you I'm feeling the anterior fontanelle. What indication does that give you?
Ma'am, deflexed head, ma'am.
That's very simple, no? What? So deflex head, if you apply a low mid cavity forceps, will your application and delivery be successful or not?
No, ma'am.
Why not? You're correct. It won't be successful, but why not?
Ma'am, the application of the forceps will not be it will not be locked, ma'am.
Yes,
Will
correct.
not.
So it is not, again, not satisfying all the criteria.
Yes, ma'am.
Yeah. Okay, wow. Correct.
Yes, ma'am.
Share it. What you know, you should answer bold, amma. There's nothing. Okay.
Okay, ma'am.
Examiner சும்மா அப்படிதான் திரு கேட்பாங்க because they'll be bored. They'd already seen about 10 candidates before you. Okay.
Okay, ma'am.
So what you know, you know. You have to answer that. You just have to be bold and answer. That's all. Nothing more. Sherry. Okay, good. Next, what? If you are applying, if suppose this was in the oblique diameter, are you happy applying any forceps or would you prefer vacuum or will you take her up for cesarean? She's been in second stage for 2.5 hours.
Ma'am, vacuum will be better than forceps.
Why?
It completes the rotation and then traction
Okay.
can be given, ma'am.
Okay. So that's supposed to be one of the advantages of vacuum over forceps. Okay. Right. Yeah. Okay, Deepa, anything you want to ask?
Nothing. So to sum up, Abhi has done a wonderful presentation. So why
Yeah,
have
very good.
yeah. Second stage, if you see the here only 3 hours is given. So like labor care guideline, that means 3 hours is the maximum you can give it to the laboring mother. Before that, as per the alert signs, we have to intervene as and when needed in even the second stage. Like if the kaput is 3+ at 2 hours itself, then we have to alert us. It's something is going on. And if the molding is 3+, then it is an alert sign. Some obstructive symptoms, even if it is a second stage. If the position is transverse or posterior, then also it is alert signs, even if it is a 2 hours or 1.5 hours. Okay. So that is how the whole labor card guide as a whole, as a picture, you have to see. And every time, whatever the discussions and getting your signature here, you have to discuss with the patient. Never left the patient unattended. You have to talk to the patient. You have to explain how far she has been. That is how the labor care guide has to be followed. So the basically in the second stage, what you are looking for in the second stage is prolonged second stage. That is if it lasts more than 3 hours, or in between if there is any obstructive symptom is going on because of persistent malposition of the baby. So all those have to be taken care, like secondary ready transverse arrest, all those things has to be done here. Then we have to act. If it is operative vaginal delivery is feasible, if with all the checklist you have told now, then you can go ahead with the operative vaginal delivery. And do not let the CTG changes. If the CTG is abnormal and if the second stage is going on for a longer time, then you have to tackle it the CTG abnormality first. Okay.
Okay, ma'am.
So the same thing goes in the late first stage also. Late first stage, why we are bother about is like arrest of dilatations. Descent is the last things. If you see, there is no part of descent has been mentioned here already. It is come to the no part of descent plotted here. It's only the caput and molding has been here. So descent is the last thing to occur. Do not worry. If the dilatation is persistently at 6 centimeters for a longer time with other changes, then you have to act at that time. So arrest of dilatation in the first stage of labor. That in there, we have to look for why it is arrested. Okay. So that's it for today. And thank you so much. Any questions in the chat box has to be answered? I think
Almost everything answered, madam.
okay, thank you. Answer for why 6 hours after prostaglandins? Why we have to do wait for 6 hours of after prostaglandin? ARM never for the color of the liquor. Why you have to look for the color of the liquor? So these are the two questions. I repeatedly saying ARM, even if it is a meconium, no worries. Even if it is a meconiums, we are not worried about anything. Meconium with fetal heart changes, then only the concerns comes. Okay, just to look for the color of the liquors, ARM is not justified.
Yeah,
Fine.
I think at the Labour Congress recently, he was saying even grade 2 meconium or thicker also, he won't bother to take any action. So that is an important point. I think we should not, that we have to stop saying that we are doing ARM to look for the meconium staining.
Okay.
Actually, we put speculum, madam, speculum and hold the anterior lip of the cervix with the sponge holder and just lightly give a fundal. If the pervaginal examination is showing like 25%, 50%, then see the pearly white color also.
So, yeah, good. I think good presentation, Abhi. But my only advice to you would be, every time an action is taken, stop and ask yourself why not.
Okay, ma'am.
That way, it will be very thorough. You can never then, you learn everything that way.
Okay, ma'am.
Thank you, everyone. Meena, thank you for
Thank you
joining.
so much.
Thanks, Meena,
Thank
for
you.
When should
joining.
ARM be done ideally is a question, madam. Dr. Meghna Mani has asked.
When should ARM to be done? Why should ARM to be done?
Ideally.
Ideally, there is no ideal. Okay. So in a labor, patient is in labor. The purpose of ARM is to only to augment the labor. So probably why you do the augmentations when there is a poor progress. So you need to document that there is a poor progress. Then only you have to do an ARM. Suppose if you are doing an purpose of induction of induction, see if the induction is like dilemma, we cannot go with another drugs. Probably you can do an early ARM for that induction. But in a labor management, active labor management, ARM is only to be done if you felt the progress is poor. You have to document the progress. That means you have to document in your clinical labor care guide that this is arrest of dilatation. That's that whether I can do ARM or I can do go CTG abnormality depending upon the you have to act on that. Okay. So ARM is basically to augment. You have before augmentation, you have to check it's a proper with the progress is poor. There is no time frame. After doing a prostaglandins, I'm doing a 6 hours later. I have to do ARM and I have to do Synto. No, if I feel the contraction is not very good, then I need to augment it. If there is no progress, there is an arrest of dilatation, then I have to augment it by doing an ARM first. Then only oxytocin, you have to give some time for the ARM, which releases the prostaglandins, which causes increases a contraction. Then only the oxytocin has to be given.
Madam, one more question. For decreased variability, how much time we can wait? Dr. Lakshmi Devi has asked, madam. For decreased variability.
For decreased variability. So in labor, a decreased variability is it we have to differentiate whether it is a period of 20 minutes or if it is continuously more than. When there is a decreased variability, look for other parameters like where what is the baseline heart rate, if it is normal or appropriate for gestational age. What is appropriate for gestational age? Someone at 39 weeks, we cannot see the fetal heart rate of 150 or 160, which is normal. So tachycardia and decreased variability more than 40-50 minutes, not good. So decreased variability is a sign of hypoxia, but decreased variability in labor for 20 to 30 minutes, followed by the good variability or preceded with a good variability, then it's a sleep cycles. You can also see the down below the other parameters. If there is a baby movement is there, then decreased variability is only a cyclicity. So you don't have to worry at all.
Madam,
So
next
I think
question.
one important
Dr. A.
point that
Sharada.
One
Deepa has
second,
just-
Madam is asking. Madam is telling.
only one
Yes,
important
yes,
point
madam.
that Deepa has
Yes,
brought
madam.
out is the fact that just looking at reduced variability, do not react. She said very clearly, follow it for some more time. If the previous CTG tracing has been normal, you can wait for some more time and see what evolves and whether cyclicity is there. So I think that is a extremely important point. Don't get excited about just another 10 extra minutes of reduced variability doesn't mean anything. Okay. Yeah. Sorry, Ma. Go ahead.
Thank you. Thank you so much, madam. Madam, next question. Dr. A. Sharada Devi has asked, how long oxytocin can be used for augmentation of labor for primi and for multi?
For both primi or multi, augmentation, as long as it's getting a good contractions, we have to, the aim is 3 contraction with minimum 3 contractions with each contractions lasting for 35 to 45 seconds. That is, the amplitude is good, then we can augment it. Augmentation for by the time we will be putting more, probably she's asking for the induction, I think. If you start for induction.
Augmentation. She has asked for augmentation, madam.
Augmentation,
Not for induction.
role of oxytocin is like there is no criteria to like within 4 hours, 1 point she has to deliver kind of things. If you see the labor care guideline, from 7 centimeter to full dilatation, almost 6 to 7 hours. So
Okay.
there is no proper thing. So you can continue oxytocin as long as other parameters are fine. And if she is progressing very well. So after 6 centimeters, you don't have to rush. 5 centimeter, you don't have to rush. She has to deliver within 3 hours, 2 hours. So if your supporting care is good, if she is mobile, if there is a pain part is tackled with epidural, maybe for 6-7 hours, then maybe will prolong labor. And if the fetal heart is good, then with the good contractions. Maintain low dose oxytocin, low dose drip. How long, how effectively? The aim is to get only 3 to 4 contraction, not more than that. So you can continue for 6 to 7 hours also fine. No difference
Thank you, madam.
as long as both the we have to get the good contractions, then only she will progress.
Okay, madam. No more questions, madam. Thank you so much, Jayashree, madam, and Deepa Tangamani, madam,
Thank
on
you, Ma.
behalf
Thank
of
you, Meena.
OGSSi. And it was a very nice discussion, madam, on LCG partogram. Dr. Abhirami, second year resident from Apollo, has really presented very well. Thank you so much, madam.
Thank
On
you.
behalf
Thank you,
of
Abhi, for your good
President Sampath,
Thank you,
presentation.
madam.
ma'am.
And
Thank
all
you,
the
ma'am.
best for you.
Ma'am, Sunita
Thank you,
here.
ma'am.
Thank you, Jayashree, ma'am. Thank you, Deepa.
Hi, Sunita. How are you?
Hi, ma'am. Yeah, ma'am, fine. Today I missed your program because, like, unknowingly I have accepted one more program. I went there.
Okay. No problem. No problem. Thank you.
We
Thank
have
you very
had
much.
the photos released in the Facebook, madam. So
Oh,
many of my friends have shared me, apart from non-OG radiation oncologist as well.
Great.
The
Okay.
photos.
thank you, Ma. Thank you, Meena.
Thank you, madam.
Thank you, ma'am.
Very well
Thank you so
organized.
much,
Romba
madam.
nalla irundhuchu. Thank you.
Thank you, madam. And new I love OGSSi எல்லாமும் போட்டிருந்தோம் இன்னைக்கு அந்த
That
இது.
was very nice, Amma.
Yes. Thank you, madam. We have shared the photo, whichever my husband has taken now. Thank you so much, madam.
Thank you. Okay, da.
Madam had also joined, but the connectivity issue cut ஆயிடுச்சு Sampath madam there. Thank
Sure.
you from President and Treasurer also and team OGSSi. Thank you so much, Jayashree madam, Deepa madam. Thank you, madam, and
Bye,
also
da.
Dr.
Thank you.
Thank you.
Rin for presenting.
Thanks. Deepa,
Thank you,
thank you.
madam,
Thanks, ma'am.
and also thanks for the platform.